Welcome to OET for you. Today we are going to discuss about upper GI tract.
But today we're focused on upper GI issues, right?
Great.
So the GI tract consists of everything from mouth all the way down to the anus.
That's right.
Tell me what is considered an upper GI.
So, as you said, GI tract encompasses from mouth to anus. So, the lower GI is what we talked about last time, and that's basically the large colon down. For the upper, it's from mouth to the second part of the small duodenum, what we call where the ligamentum of Treitz lay. That's the geographic zip code or state line that separates the upper from the lower. So the upper tract is anything above that. So it's above from the second portion of the duodenum to the stomach, to the esophagus, to the mouth.
Okay, great. So I'd like to identify some common upper GI problems people may be living with, and then I'll ask you some questions regarding each disease.
Sure.
I want to start with reflux versus GERD, because sometimes I feel we hear both kind of going together. And is GERD the same thing as reflux?
So GERD is a gastroesophageal reflux disease, and it encompasses, it's a broader terminology. So GERD may or may not have regurgitation component to it. So GERD just means whether it's acid itself or acid vapor coming out of the stomach and above the door that separates the esophagus and the stomach. So acid in the stomach is fine. You know, acid is produced in the stomach, it's stored in the stomach, and it's supposed to work in the stomach.
Yeah.
When acid is either produced too much or it's produced in normal production, but you have it coming up out of the stomach into the esophagus, that is under the classification of GERD or heartburn. Regurgitation is when you actually have consumed food and the food's being digested in the stomach, but the food content itself comes all the way back up to the esophagus. That's the regurgitation component. So you can have GERD with or without the regurgitation component.
Okay, so I want to talk about obvious symptoms and not so obvious symptoms of GERD. First of all, obvious symptoms.
Obvious symptom would be the classic heartburn. You know, you ate your large meal, whether it's cheeseburger and fries and a Coke, and then 10, 15 minutes later you feel a lot of burning, pressure.
In the esophagus.
Yeah, and then you feel like acid coming up. And they classically describe it as it's coming up. They usually point to their chest, and it may come all the way up to the throat. That would be the obvious symptoms of heartburn, and it usually happens after a large meal or a spicy meal. Most people know their triggers, and that's what is most common and most frequently described.
Okay.
Not so common would be what we call atypical GERD. So some people may just, for whatever reason, they don't feel the heartburn at all. They're just astounded. I don't feel any heartburn at all, but my only GERD symptoms may be they have a persistent cough, or their voice is out, they're hoarse all the time, or they actually feel food getting stuck, or some people think they are actually having a chest pain or a heart attack when in fact they're just actually, that's their GERD symptoms.
Wow.
So that's not so often, but what we call atypical, not common presentation of GERD.
So GERD, you can have a dry cough from it, and you could feel like something is stuck in your throat.
Sure. So that's something I want to definitely clarify,
please do.
because cough and hoarseness or having a sensation of something at the back of the throat is such a broad description, and so many things can cause that. So it could be from cigarette smoking, or it could be from secondhand smoke. It could be because you live in Cleveland and we have allergies here literally from spring to fall.
Sure.
It could be allergic reaction, seasonal allergies, or it could be some dryness of the whether you have scleroderma or some kind of autoimmune disorder that dries out your mucosa. It could be an asthma can present with those things too. But one of the possibilities of that, it can be atypical or uncommon presentation of GERD.
Okay, so what you were saying right now, the symptoms was for more of a cough, correct?
Right.
That's what you're saying. What could have caused it? What causes GERD?
So what causes GERD is many different things. So either A, your stomach overproduces the acid, and there's so much acid in the stomach that it has no other option but to splash upward and out of the stomach and up into the esophagus. So that could be one. Another could be that there's a door that separates the end of the esophagus to the stomach, what we call lower esophageal sphincter. And your lower esophageal sphincter may be malfunctioning or too weak. And if it doesn't shut tightly, it's almost like gaping open all the time. And so it allows stomach acid to reflux up to the esophagus too frequently or too many times.
Are there dietary restrictions for people with GERD?
So the first step would be, our recommendation would be dietary restriction. So that would be just kind of common sense things. No excessive alcohol. Smoking lowers the muscle tone of the lower esophageal sphincter. So we say no smoking, avoid excessive alcohol, avoid spicy foods, because that can definitely make your heartburn symptoms worse. We recommend avoiding large, fried, greasy meals because those hard, fatty meals are difficult to digest, so they stay in the stomach longer. So if you have this solid meal in your stomach, then it makes the gastric acid rise to the top.
I see.
So that's why simpler foods that are easier to process tend to help with people who suffer from GERD.
How about something like citrus or like tomatoes?
Right. So that's a good point. A lot of specific foods are triggers for people who suffer from GERD. So a lot of times people say anything that has tomatoes or tomato paste or pizza sauce. A lot of people have different triggers. So some people, it may be tomato paste or citrusy, like grape juice or orange juice. But others may have, they may have, their trigger may be Mexican food, or another person may be Chinese food. Another person may be Italian food. So it kind of varies from people to people because your trigger may be a little bit different than your neighbor's.
All right. And treatments?
Treatment kind of depends on the severity of your symptoms. So if it's mild, you could just take Tums or Pepto-Bismol or Maalox. If it's really mild and short-lived, then you can take those and just treat as needed. If it's severe or more persistent, meaning you have it every single day, and now you're almost having like a panic attack because you're like, if I eat that, I'm going to be paying for it for the next 2-3 hours. Then you can think about taking medication for it. So the first line, the lowest line would be what we call H2 blockers. So that would be over-the-counter Tagamet, Pepcid, Zantac. You can buy those over the counter. You can take them twice a day as needed. But again, those are the first line therapies. Now, if you have a bigger fire to put out, then that may not be potent enough for you. So then you can also, now they're over the counter, they're called the PPIs, proton pump inhibitors. So they're much more powerful. So that would be the Prilosec, Prevacid, Acifex, Nexium. You can buy those over the counter as well.
Oh, okay.
If those don't have enough, a lot of patients say, that helps, but it doesn't last me long enough. Well, then you can go to, you see a doctor and get a prescription strength.
Okay.
So it's a higher dose, so it'll last longer.
Good. All right. And then peptic ulcers. Why do first of all, what are they? I'm guessing there's some kind of ulcer, but where are they located and why do they occur?
So peptic ulcer means any ulceration of the breakdown in the mucosal lining where you actually get an ulcer develop, and that could be anywhere between the stomach, the duodenal bulb, and the duodenum. Before the early 80s, peptic ulcer disease was pretty prevalent and pretty severe. People would actually have stomach perforations. Wow. They would have to come in the emergency room and they would have to have surgery, and the surgeons would do what we call wedge resection, like almost like a pizza wedge, and then they tied the two healthy lines together to cut the ulcers out because we were unable to heal them. But since the invention of acid-reducing medications like the Nexium, Prilosec, omeprazole, Protonix, pantoprazole, there's a slew of brand name variations, but they're all proton pump inhibitors. They're extremely effective. So they decrease the acid production. And I mean decrease. They don't stop the acid production. They just decrease it so that you don't have a pathologic amount. So that you allow that ulceration or that break in the mucosa, allow it some time to heal. Okay.
Now, is H. pylori, that bacteria, is that related to peptic ulcers?
Yes. So Helicobacter pylori is a bacteria. It can complicate a peptic ulcer disease because
Okay.
what it does is the bacteria infection actually breaks down the mucosa. So you can you're at higher risk for developing peptic ulcer disease, and you're at higher risk for that peptic ulcer disease to penetrate bigger. So it can penetrate down to a point where it erodes through an artery, and you can present to the emergency room with an upper GI bleeding from an arterial source, or it could be a slow leak where you see you see blood in your stool, and you present with anemia.
Oh, wow. So when you say bleeding, it is all coming out when you're in the restroom?
Right.
So cough it up? Or?
Right. So your intestinal tract is a closed circuit. It's a closed plumbing system. There's only two openings, mouth and anus. So if you're bleeding in your stomach, if you bleed a lot, that blood will make you nauseous, and most people will vomit up blood, called hematemesis. So you're vomiting up blood. If you're bleeding a little bit, kind of like a faucet where you have that little drip, then it's not enough to make you nauseous. So you may not vomit it up. So if you're not vomiting it up, the only other route is to go down. So eventually you'll see it in the stool. If you're having bleeding from the upper tract, once it gets hit with hydrochloric acid, bile, and digestive enzymes, it gets digested through the digestive tract. So by the time it comes out in your stool, it'll present as black color.
Wow.
So it'll look coffee grounds or tar or asphalt kind of looking. It's sticky, it's black. It's very hard to flush, so people have to flush a couple of times because it likes to stick to the side of the bowl.
Wow.
Those are concerns that you might be having an upper GI bleed.
Okay.
And so those you really want to get that checked out and corrected so that you don't have to get a blood transfusion or whatnot.
Yeah. Wow. All right. So any dietary restrictions for people with peptic ulcers?
Dietary, the food in itself doesn't cause the peptic ulcer disease. Usually the number one cause of peptic ulcer disease is usually stress, whether it was you're in the intensive care unit, you're intubated, you're on a ventilator. That kind of bodily stress, decreased blood flow, puts you at risk of vulnerability for mucosal breakdown. If you're on high-dose steroids or NSAIDs, Motrin, anti-inflammatory medications that kind of decrease your mucosal buildup or integrity, puts you at risk for peptic ulcer disease. As you had mentioned, the H. pylori, that's a bacteria infection that kind of compromises the integrity of your mucosal lining. That can accelerate the peptic ulcer disease developing.
What happens to the ulcer if it's left untreated? Does it get larger, or does it get more complicated? Can this become a surgery, just like you said?
So it depends on the patient. Most of the time, since the advent of proton pump inhibitors, most of the ulcers, almost all of them, gets fully eradicated or resolved and healed with just taking the medication for 12 to 24 weeks, depending on your ability to heal. People, if you skid your knee, people heal at a different rate. So some people take a little bit longer. Some people may need an extra 12-week course of the medication to completely heal. Rarely, it's not responding to peptic ulcer. It's not responding to the proton pump inhibitors, and that may be because they have a cardiac condition. And they can't get off of certain medication that puts them at risk. And, the high-dose aspirins or the clopidogrel, those antiplatelet medications that put you at a little bit higher risk for peptic ulcer disease. So if they can't come off of these other agents that increase their risk of peptic ulcer disease, then in a very few rare situations, they may still need to have surgery to have that heal. But that's really very, very rare in this day of PPI availability.
So I know you talked about stress, and that was actually one of my questions. What I want to ask you, so for prevention measures, lower your stress, that will fix, not cure, but maybe the symptoms for ulcers?
So it depends on the person. So some people, if they're under stress, whether it's family stress, work stress, or financial stress, their stomach, there's little cells in the stomach called parietal cells. So they work in overdrive, and they start making a lot of hydrochloric acid. So then they get themselves in trouble because they have too much acid. Now, other people, stress may not excite their parietal cells, and their acid production may be the same. So it's really hard to say that stress causes everyone to have this issue. It just affects some people, and in others, it doesn't. When we also talk about stress, we don't really mean just the stress as we know it. We also mean physical stress. So if they're on chemotherapy or they're on prednisone because they've got rheumatoid arthritis or they've got autoimmune, liver disease or some other medical stress that puts a stress on their physical being, that can actually increase their risk of peptic ulcer disease as well.
Okay, that's a good point. Okay, so what does it feel like? Because you said they could show up in different places. Is it just like a really painful what?
So, human beings are amazing. They have such wide variability and wide presentations. I've had patients that had the most notable ulcer that you would think, oh, it's so big. It's so impressive. Yeah. But they may say, I don't have any symptoms at all. They'll swear up and down they have no pain, they have no issues, and the only reason they came is because the primary care doctor insisted that they see a GI doc because on a routine health physical, their blood count was lower. They have anemia. And so sometimes they come all disgruntled because they're like, I have no symptoms. I don't know why I'm here. My primary care doctor is just adamant and insistent that I see you, but I have no symptoms. I have no pain. And you really almost have to talk them into, hey, listen, I understand that, but your blood count's all been normal all this time, but all of a sudden, your blood count's low.
Yeah.
So we have to kind of figure out, why is it low? You must be losing blood somewhere. And so that's when we may have to do an upper endoscopy to take a look, and we can see impressive ulcerations, and that may or may not be bleeding at the time of the endoscopy, but we can, show that to them. Then we also have the other spectrum of presentation where they have just a little bit of irritation or just a little bit of acid inflammation, but they have 20 out of 10 symptoms. So it's hard to connect the severity of the ulcer or reflux with the symptoms that they have. Kind of like, for example, people that have a heart attack, most of the time you're supposed to have chest pains, crushing chest pains, like elephants sitting on your chest. But other times there are many people who have absolutely no chest pain at all, and they have completely unaware that they're having a heart attack. And then other people come and say, all I had was left arm tingling or neck pain. Now, no one has a heart in their neck or their arm, but that's the only area that they felt
they're feeling
it. So it's a referred pain. Likewise, for peptic ulcer disease, some people could have the classic boring, they feel like somebody's being stabbed with hot iron. They can say, it's boring pain located right here. Well, they're really helping us out. That's like right out of a textbook, and you're like, oh, you got a peptic ulcer disease.
We got this.
But then some people will say, like that gentleman that I saw, he had no symptoms. He says, I feel like $1 million. I don't even know why I'm here. I'm so mad at my doctor for making me come. And, well, not so mad, but just a little perturbed that they have to do this. But, they had a significant ulcer disease.
So I wonder this. Could it be high pain tolerance, or could it be someone that's maybe used to the pain for so long and they thought this was normal? Do you think that has anything to do with it?
I've had people that come and say, you know what, I have the highest pain threshold that you can imagine. I did X, Y, and Z with no anesthesia. But, that may be true, but our pain receptors are not uniform throughout our entire body. So it would be like, think of the most burliest guy who have, they can do anything and they have no pain, but maybe they have teeth sensitivity. They can't bite into an ice cream, right? They'll be like, oh, that's intense pain. So our level of pain sensation and perception is not uniform. So I don't want the patient to think, oh, just because I can endure X, Y, and Z type of pain, that I may not feel this, because that may or may not be the case.
Very well said. Thank you. Okay, so gallstones. First of all, is that considered upper GI?
Yes.
Okay,
yes.
I just wanted to make sure. So what are those little stones made up of?
So those stones are very common. Majority of the time, about 75% of the time, they're made out of cholesterol stones. Those are the most common. About 20% of that next category is what we call pigmented stones. So they're called black stones. And so they have more of a bile pigment and some blood. And that's why it looks black stones. And then the smallest category, maybe 5%, is what we call the brown stones. And those are from parasitic infections mixed with blood. So
Oof.
there's 3 types of stones.
Okay,
Now, that would be in the U.S. In a third world country, that
could be
ratio
different
will be very
factors,
different.
sure.
But in the U.S., a land of plenty, majority of our stones are more cholesterol-based and not parasitic-based.
So if someone gets gallstones, does that mean that they have high cholesterol?
Not necessarily.
Okay.
Yeah.
No.
So
Right.
the gallbladder is a very small organ that's
Yeah.
tucked away under our right rib cage in our liver. It's almost like a balloon that you see. So it decompresses and it can expand and decompresses. It's a small storage unit that stores bile, so that when we eat a fatty, greasy meal, that bile gets dumped quickly and it's able to emulsify the fat content of our food. So we don't all have fat-induced diarrhea. So it's very helpful. But what happens is if the cholesterol precipitates out and starts accumulating in that little gallbladder sac, then you can develop stones. So that doesn't mean that you have high cholesterol in your body necessarily.
Right,
Just means in that little gallbladder sac.
And fun fact, removal of the gallbladder is one of the most common U.S. surgeries. I didn't know that until I read that. That's very interesting.
That and appendectomy.
So symptoms of gallbladder, a lot of pain on your right side. Could there be any other symptoms that
So a
are not
textbook
natural?
presentation would be right upper quadrant area where your right rib cage kind of ends.
Okay.
And typically textbook presentation would be after a fatty, greasy meal. You start having pain about 15 minutes later. It may last about an hour or two. It's colicky, meaning it comes in waves. It may, and generally located right upper quadrant to maybe the middle area, but generally it stays in that locality. It doesn't spread anywhere.
Okay.
Sometimes it can spread, you can get referred pain to the right shoulder,
Okay.
But for the most part stays in the right upper quadrant area. About 15 to 20 minutes after a meal, lasts about 1 to 2 hours.
Okay. All right. And jumping on to lactose intolerance.
Okay.
A lot of people have that, but let's talk about the textbook definition and what is actually happening in our bodies.
So lactose intolerance means most of us have an enzyme called lactase, and it helps digest the sugar in the milk called lactose.
Okay.
Most of the population have lactase that's sufficient, and we don't really suffer from it. However, there are certain cultural groups that are genetically have low lactase level, like Asians and Hispanics, that's one. But that being said, in the general population, as we get older, you may lose a little bit of lactase ability.
Okay.
So even if you were completely able to have milk when you were young, you might find as you get older, you may be less tolerant of the lactose load. And sometimes it has to do with the amount. So some people could have a little cup of ice cream, but if they have 2, they're in trouble.
Right.
So that means their lactase level is still present, but they don't have a whole lot of it.
Okay.
So
And it changes with age. It could definitely change with age.
It can decrease with age, but some people are able to maintain their lactase activity throughout their whole life. All
right. And the symptoms of that, constipation or diarrhea or both?
Well, so the textbook presentation is after a large lactose ingestion, whether it's dairy, so milk, yogurt, cheese, any dairy product. Within 20 minutes or so, you get excessive bloating, abdominal cramping, and most of the time it's supposed to present with diarrhea because you're unable to digest the sugar of the dairy product, the lactose. So you have what we call osmotic diarrhea because you're not able to digest it, so it just gets expelled out of your body. So you'll get a good bowel clean out.
Yeah. So can you test for this if you feel like...
You can. There's a breath test that any doctor can order for you, and you go and there's a breath lab facilities, and they make you drink a liquid that's just lactose. Ooh. And then 10 to 15, 20 minutes later, you blow into a bag, and they're measuring the hydrogen content of your, just to see if you're malabsorbing.
What you're going
now, that being said, that's very scientific and nice, but you could really do those at home. You could drink 8 ounces of milk, and if you have no symptoms 20 minutes later, then you're good. If you have abrupt symptoms within 15 to 20 minutes, then you have your answer, and you could just save yourself a very expensive test.
Okay, that's very good to know. All right. So swallowing disorders, real fast. I mean, it seems like there are many. Yeah, so what constitutes a swallowing disorder?
So swallowing disorder is pretty complicated. So it can encompass anything from difficulty of taking the food in the mouth and transferring it down to the stomach.
Like swallowing.
Right.
Okay.
So none of us really think about it because it's done out of reflex, natural reflex. But there's a lot of mechanical steps that take place without our knowledge. Kind of like our heart beats all the time and we don't even think twice about it. Swallowing is the same thing. It really starts from the time you looked at your food and you're thinking about eating it. So then your mouth gets preparation started by making saliva, making your mouth moist, your tongue's getting ready. And then when you kind of take it into the mouth, there's that accepting phase where your lips are involved, your tongue is involved, your saliva is involved. It's got to accept the food into the into your mouth. And then the second phase is that transference phase where the back of the tongue and the palate is all involved in chewing the food and transferring it to the back of the throat. Now, at the back of the throat, there's two pipes. You have the windpipe and the food pipe. So when swallowing, without our consciously thinking, our air pipe or windpipe is closed, and then the food pipe is open. So then the food gets transferred to the food pipe, and then you have the esophageal phase, and then it goes to the stomach. Now, many things can go wrong in those steps. So most common would be if you had a severe stroke, an ischemic stroke, or you have some neurologic muscular dysfunction where that process is no longer properly executed without your conscious sedation. So what can happen is you can chew and chew and chew, but they can't transfer.
Wow.
Or you can chew and chew and chew and transfer, but then that flap goes to the wrong pipe. So you're actually aspirating food to the windpipe. Wow. Then the last phase is it can actually get transferred successfully to the food pipe, but then your esophagus isn't efficient or it's pathologic and it's unable to shove it all the way down to the stomach. Yeah. So there's a lot
that
of
sounds
steps
like a
involved.
very difficult disorder to live with. What are the treatments for something like that?
Well, that varies. It depends on what the cause is. If it was due to a severe cerebral vascular accident, like a stroke, then the way is to go with a physical therapist and try to retrain how to swallow and recruit extra other muscles to help for the muscle that you've lost. So they can try to retrain how to swallow or use different techniques to augment the function you've lost. So if it's a CVA related, you can do physical therapy or not whatnot. If it's a infiltrative process, meaning neurological issues, whether you have MS or Guillain-Barré or you have ALS, those are it needs to have a neurologic issues
approach to it. Because I'm thinking you can't really take a pill, right?
Right, that's correct. That would be so nice.
Deal with that? I know, right? That's what I'm like, that
and then for
difficult.
our part is in the esophagus, if you've developed scar tissue, what we call Schatzki's ring or stricture or mass, then depending on if it's a Schatzki's ring, we can just cut it out and take care of it for you. Or if it's a strictural thing, we can dilate it for you. If it's a mass, as long as it's small enough, we're able to remove it for you.
Okay.
If it's cancer, then it's a different story whether it's resectable or not resectable.
Okay. So let's see now. Thinking about something like burping or belching.
Yes.
Could it be if excessive? Is that a disorder?
It is a disorder.
Yeah, let's talk about that.
That's a fun topic because also the etiology of that is very wide.
Yeah.
It could be actually anxiety presentation. A lot of people, when they're very anxious, they don't realize they're doing this, but they have something called aerophagia. They're swallowing the air. And they have no idea that they're doing it. They've actually done a study where they put these people in on a radio labeled air and they can see it go in and they swallow it and they go to the stomach and it comes back out.
Wow.
So that's called aerophagia. So it could be a manifestation of an anxiety disorder. Another could be that you actually have excessive gastric acid, and the gastric acid causes a lot of...
It's causing the belch.
Yeah, the excessive buildup of the air, and your lower esophageal sphincter is weak, so it doesn't close it. So instead of the air going down, it's coming back up. So that could be a presentation of acid reflux disease. Another thing would be, unfortunately, neoplastic. If you are having a cancerous issue process of the lower esophageal sphincter and it can't close, then it's just a freeway going in and out. So those are many different presentations.
Now, one last question for you, and this is probably a hard one because that's the one that I struggle with my kids, or when someone tells me I have abdominal pain. Man, that is hard to pinpoint what could be the issue. You know, like how do you tell if you know? I mean, I'm not the patient, but if I am a patient and I'm feeling some kind of pain, how do I know where that pain is coming from? We have so many organs in our upper GI.
So the best thing is to actually lay them down. You want to lay them down because when you're sitting, everything's kind of scrunched up, and so it's like all on top of each other.
Okay.
I always tell patients your abdominal cavity is kind of like a suitcase. So you know you on top of each other. That's exactly right. So the best way to best locate or localize is you lay them down. What that does is it stretches everything out. So you have them point with one finger where in your abdomen, because sometimes people say I have stomach pains, and when I ask them to point, they're like pointing down here, and I'm like, that's your bladder, that's not your stomach. So your stomach's all the way up here. So they mean abdomen. So those words, stomach and abdomen, gets interchanged.
Okay.
So the best scenario is you lay them down, ask them with one finger where the location is. So that helps limit your differential. So clearly, are they pointing to your liver, or are they pointing to their stomach, or are they pointing to their bladder, or they're pointing to your appendix, or you know their spleen. So the location kind of can help you narrow down the possibilities.
Okay,
so.
and then Google it.
No, don't Google it. That'll just terrify you. Call your local friendly primary care doctor or neighbor who might have some medical contact.
Right. Now, are there any other upper GI issues that are common that we didn't talk about?
Oh, yeah.
I mean, there's a lot. I know there's a whole lot.
Yeah, so right now there's a lot of, whether it's a dietary thing, there's like EOE, eosinophilic esophageal esophagitis. That's more of a allergic process that affects your esophagus. You had mentioned the H. pylori, that's a bacterial infection. A lot of people are popping anti-inflammatories because of muscle aches, because they're training for a marathon or whatnot, or weightlifting, so you can have peptic ulcer disease. There's other things that are not as common, but those that we look for, you know, like carcinoid or you know, gastric cancers. We don't want those, but, you know, we have to make sure that we're on the lookout for those things. Sure. And then inflammatory bowel disease, like Crohn's disease, can affect anywhere in the intestinal tract. It's
so
not
it could
just
be upper, not just lower.
It's not just limited to the colon. So Crohn's disease, which is an autoimmune disorder, it's not contagious, but it can attack anywhere in the intestinal tract.
Sure.
And another one is something called gastroparesis. What that is the motility of the stomach is greatly slowed. So when you consume a meal, depending on the meal, there is a stomach emptying time. When that stomach emptying time is greatly delayed, a condition called gastroparesis is diagnosed. And what that does is patients ate a meal maybe 16 hours ago, but it just sits there. So it causes a lot of discomfort, a lot of pressure, lack of appetite. They haven't eaten anything for 16 hours, but they're still full.
Feeling full. Is it lack of digestion then? Is that a part of it?
Usually there's different causes. So the most common cause or etiology for gastroparesis is diabetes. So the long periods of high sugars causes neurologic changes of the motor neurons in the stomach muscle wall. So it just is sluggish. It just doesn't move. It doesn't recognize the food is there, and it's not grinding it. It's not pushing it out of the stomach into the small bowel so that the digestive tract can start working. So that's the number one cause. But there's other causes for gastroparesis. The second most common is medication side effect. A lot of patients are on pain medicine because they had a hip surgery or knee surgery. Or some orthopedic surgery that's extremely painful, and they get put on pain medication in a form of narcotics, and all of those causes delay in gastric emptying time, but you won't feel it because it's a pain medicine. You can't feel pain. You're not going to feel that your stomach's not moving either. There's other, even less common causes of gastroparesis are unfortunately infiltrative disorders, whether it's a linus plastica, it's a form of gastric cancer, or a form of what we call malt lymphomas, or it's a cancer of the stomach lining, but it's a form of neoplastic changes that causes the stomach not to function. So there are different causes, but most commonly being gastroparesis being diabetes.
Sure. Is H. pylori painful?
H. pylori in itself should not be painful.
Should not be painful.
Yeah. So, but once you have an ulcer, the patient may or may not be aware of the symptoms. So they may or may not have that boring pain.
Yeah. So if I'm having pain in my abdomen somewhere, the best way to tell if it's an ulcer, besides you're questioning me, is what? Like a EGD?
Yeah.
Okay.
It
To
really,
get it-
if
to
you
get that
wanted a
done.
definitive answer, it would be
Need
an
to get in the
upper
right camera.
endoscopy, because what that would do is you'd come in on an empty stomach. We would just give you a little sedation so that you're a little sleepy. And while
Yeah.
you're sleepy, we slide the scope over your tongue, down the food pipe into the stomach. And, you know, that lens is almost like a low-level microscope. 1 millimeter lesion is just really greatly magnified, so we can see quite a bit. And we can look for ulcers, polyps,
Yeah.
anything that's abnormal.
And I want to ask you about the endoscopy, just because it's the first thing that comes to my mind,
Yeah.
and maybe some of our listeners. But that endoscopy going down your throat, even if you are a little bit on twilight, you know,
Very well
drugs,
tolerated.
It is.
It's very
You don't.
nerve.
There's no gag reflex.
There's
that
a
people,
lot of anxiety associated with it, but
That'd
it's
be
a very
me.
safe procedure. They've been doing it for many decades.
Okay.
It's really a 5-minute procedure, and for those of us that do it on a daily basis, your safety and comfort's our first priority.
Right.
So you get an IV in your arm. We do give you what we call twilight sedation.
Yeah.
Most of the patients won't remember what happened, but it's only 5 minutes. But we make sure you have enough anesthesia that you're comfortable, and you're
with
not
the whole thing.
anxious.
Okay.
And the scope is really smaller than any bite-sized meal that we have, and it's very flexible.
Yeah.
With a light and a camera, and so we just kind of go slide it over the tongue while you're sleeping, go down the food pipe, and take a very careful look around to make
Yeah.
sure that there's nothing concerning in the work.